forward. You guys should have notification. Perfect. All right, I'm going to turn my audio up as well. All right, so as people continue to join us, I will let them in, but we'll go ahead and get started. It's 5 past the hour. So for those who don't know me, my name is Dr. Carolina Sweldo. I am double board certified in both obstetrics and gynecology, as well as reproductive endocrinology and infertility. That is 4 years of residency, of OBGYN residency after medical school, followed by 3 more years of an infertility fellowship or subspecialty. So you may hear that as different names. I have had the opportunity to speak both nationally as well as internationally, and I do consulting as well as practice clinical medicine. So today, we are going to be focusing on PCOS. For those who might be new to me, I do have a pretty significant online presence. You can find me most active on Instagram. I also have a Facebook page as well as a YouTube channel where I drop regular videos. And all of them are the same, Dr. Carolina Sweldo. This month, we've been focusing heavily on PCOS or polycystic ovarian syndrome. And so with that, I wanted to go ahead and provide just a little bit of a deeper dive for those who may be interested. As I mentioned before the recording, there will be a replay available to everybody who registers. So if you're not able to make it live, don't worry, I will be sending this out afterwards. After the recording is completed, we will be doing a live Q&A at the end. So let's go ahead and get started. PCOS, first, I just wanted to define it, what it stands for. In medicine, we love our acronyms, and I think sometimes we forget that patients may not know what we're talking about. So PCOS stands for polycystic ovarian syndrome. And it really is a misnomer because a lot of patients will tell me, oh, I was told I have PCOS, I have cysts on my ovaries. PCOS is not cysts on the ovaries. PCOS is, however, one of the most common causes of female infertility. It affects anywhere from 6 to 12% of US women of reproductive age. So when you convert that into numbers, it's approximately 5 million women here in our country. PCOS is a complex disease. It has reproductive, metabolic, and psychological components to it. And we're going to be talking about all 3 of those today. So the concept is that PCOS is a constellation of signs and symptoms. It definitely is not cysts on the ovary. So signs and symptoms of PCOS, let's talk about that. So we said it affects anywhere from 6 to 12% of reproductive age women in the US. Generally, it's going to present in adolescence or in early adulthood. So more than likely, the patient will present with a year or 2 of regular cycles, and then eventually they become irregular. It typically presents, as I just said, with irregular menses. They can be either very infrequent or potentially no periods at all. I do have women who come to me after a year or 2 of no menses whatsoever. It may be accompanied by signs of elevated testosterone, like acne or male pattern hair growth. That may also include oily skin, severe late onset or persistent acne that does not respond well to usual treatments. So those are the 2 mainstays, is the irregular cycles and the elevated testosterone presenting clinically. However, there are many other features in the PCOS diagnosis. And as I mentioned earlier, it is a complex disease, and it does require a formal diagnosis by a healthcare provider who is knowledgeable in PCOS. So you can't just look at someone and say they have it. You can't just, oh, you have irregular cycles, you have PCOS. There has to be a constellation of signs and symptoms and a proper diagnostic evaluation. But generally, this is how it's going to present: irregular cycles and some form of elevated testosterone. If you guys have questions throughout the presentation, please throw them up in the chat box. I will be accessing that chat box after the presentation for our Q&A portion. Okay, so this is really important, I think, especially for our adolescents or our young adults. Not having periods can actually be a blessing, or it's a good thing because then they don't have to worry about it. But really, if you are a healthy woman of reproductive age, you should be getting a regular and predictable monthly menstrual cycle. Now, there is one caveat to this. So you may be on a form of birth control that has hormones in it. So I'm not talking about condoms, and I'm not talking about the copper IUD. It's going to be any form of hormonal birth control, such as the pill, the patch, the ring, the implant, or the progesterone IUD. These may impact your cycle regularity and your cycle flow. So it's really important when you're talking to your healthcare provider that you make them aware of any birth control you may be taking. But if you're not on any of those and you are a young woman of reproductive age, you should be getting a regular, predictable monthly period. So as I mentioned in the beginning, PCOS has reproductive, psychological, and metabolic components. And we're going to be talking about those next, because I think a lot of times we focus on the irregular cycles or the lack of ovulation, and we don't spend enough time talking about the general health implications that PCOS can have on a woman's body. So PCOS and general health, there's actually 2 whole slides on this, and this is really important. So number 1, insulin resistance. You also may know it as prediabetes or diabetes. We know that more than 50% of women with PCOS will have insulin resistance to some degree. And so again, prediabetes or diabetes. We know that women with PCOS have a 4-fold increased risk of developing diabetes in their lifetime, regardless of their BMI. So regardless of their weight, regardless of their family history. Therefore, if you have a PCOS diagnosis, you should be getting your sugar levels checked once a year as part of your annual checkup, because you do have that increased risk for developing diabetes. We believe that it is due to altered metabolism or altered regulation of the insulin hormone because of the underlying PCOS. Number 2 is going to be obesity. We know that in women with PCOS, obesity may result from imbalanced hormones, increased deposition of fat due to higher insulin levels, and metabolic dysfunction, or it can be from a combination of these. So when I'm counseling my patients who have PCOS, I do talk to them about the likelihood that they're going to put on weight more easily and the likelihood that it's going to be more difficult for them to lose it. And again, it comes back to increased fat deposits because of the insulin dysregulation, the imbalanced hormones that are going to favor obesity or weight gain, and then also the metabolic dysfunction that goes along with the disease. One that we don't talk about a lot is heart disease, and this is super important because we know that several studies have found increased risk for coronary artery disease, high blood pressure, atherosclerosis, which is basically just plaques that clog your blood vessels, and cardiomyopathy. And so women with PCOS are at increased risk for all of these things. So when I'm counseling patients, we're talking about really wanting to protect that heart by having to work just a little bit harder on the lifestyle component. And we'll talk about that when we go to get to treatment of PCOS. But I think, again, coming back to PCOS, there's such a focus on cycle irregularity. There's such a focus on no ovulation that I think a lot of times we don't spend enough time talking about these things. So insulin resistance, remember that's going to be prediabetes and diabetes, obesity, and heart disease. Those are not the only ones. We also know that women with PCOS are at much higher risk for having sleep apnea than women without PCOS. Again, that risk is irrespective of height and weight. However, if the PCOS woman is also obese, her risk just increased even further. So as patients are navigating their fertility and their general health, we know that sleep apnea can increase the risk for chronic diseases. We know it can increase the risk of heart disease. We also know it can increase the risk for fertility. So when we talk about managing PCOS in the setting of trying to get pregnant, evaluating for sleep apnea is actually going to be an important component. Mood disorders. This is a big one. And I think, again, it's one of those that we just don't talk about enough. Women with PCOS are more likely to have mood disorders such as depression and anxiety. And I'm sorry if the captions are affecting some of the slides, but I did want to make sure for those who couldn't listen live that they actually had access to listen to or to be able to see the audio. But mood disorders are more prevalent in women who have PCOS. The mechanism why is poorly understood, but we do think that it ties back to the hormone imbalances and the impact that has on some of the neuropathways. And lastly, metabolic syndrome. And this is summarizing, it's a syndrome that summarizes a few of the things we were talking about in the last slide: insulin resistance, high blood sugar, obesity, high cholesterol, and high blood pressure. ACOG, which is the American College of OBGYNs, estimates approximately 1/3 of women with PCOS actually have metabolic syndrome. So this is huge. When a patient has a diagnosis or a label of PCOS, we need to be sure that as healthcare providers, we're assessing for all of these other general health components. There's one other one that is really specific to PCOS that is really important to talk about, and that is cancer of the uterus. We know that PCOS is a state of unopposed estrogen. So you have higher estrogen levels circulating that never gets balanced out by progesterone. And without getting too technical, the idea is that estrogen is a stimulant for the cells of the lining of the uterus, okay? And so those cells are constantly turned on, they're never turned off, and eventually they can become abnormal. We'll talk about that more when we get to treatment of PCOS, but cancer of the uterus, specifically endometrial cancer, is super, super important that we as healthcare providers are preventing in our patients with PCOS. Okay, so how to diagnose PCOS. And, I'm currently practicing in the Central Valley, and I think generally speaking, there's a really good workup for women who have irregular cycles. But that is not true for all parts of the country where I've lived. And I know that many times women can be told, oh, you have irregular cycles, you have PCOS, or, oh, you're obese and you have acne, you have PCOS. And really the idea is that you want to establish objective criteria as much as possible to determine whether the patient actually has the diagnosis. So the Rotterdam criteria has been around now for over a decade, and it's called the Rotterdam criteria because they actually met in Rotterdam, Netherlands. It was a group of experts who came across the world and said, well, when we're doing research studies, when we're counseling patients, what are we going to call PCOS? And so this is really where the Rotterdam criteria comes from. Remembering that PCOS contains a wide array of signs and symptoms. So there's not a single test that we use to diagnose it. If you think about diabetes, we're looking for a certain threshold for the blood sugar or the hemoglobin A1C. When we're looking at high blood pressure, we're looking at certain numbers of the systolic and diastolic blood pressure when we're taking somebody's blood pressure. PCOS does not function that way. There's not one marker or one number above which you have it, below which you don't. It's a constellation of signs and symptoms. And so we're looking at the patient from a global perspective to say, okay, does this patient meet enough of the criteria to be able to receive a diagnosis of PCOS? Remember, it's a syndrome, not a disease. So number one, irregular cycles. The technical term for that or medical term for that is oligoanovulation. You may also hear oligomenorrhea or amenorrhea. In the new world of electronic medical records and us reading doctors' notes, I want to make sure patients know what terms we're using. Basically, this is if you're skipping periods. So you go 2, 3, 4, 5 or more months without a period, that's going to be irregular cycles. Number two, clinical or laboratory signs of elevated testosterone. Again, the technical term there is hyperandrogenism. And we mentioned some of those earlier. The male pattern baldness, the male pattern hair distribution around the face, persistent acne, oily skin. Those can also present in the chest, back, abdomen, or groin area. And then lastly, polycystic ovaries on ultrasound. Specifically, it's not just, oh, they look polycystic. There's actual specific criteria. We're looking for an ovarian volume greater than 10 centimeters cubed or greater than 12 antral follicles on an ovary. Now, think of the ovary like a chocolate chip cookie. We're looking at the amount of cookie, that's the volume, and then the number of chocolate chips on it. Those are the antral follicles. So an ultrasound technician or a physician can actually measure the ovary, measure the chocolate chips on that ovary, and tell whether that ovary meets criteria for polycystic or not. Of course, you want to rule out other causes. And of these three, you need 2 out of 3 to meet the Rotterdam criteria. Notice that obesity is not on there. Notice that prediabetes or diabetes is not on there, but those are very commonly hand in hand with the PCOS diagnosis. When I talk about ruling out other causes, that's super important because we know that thyroid disorders are very common in reproductive age women, and thyroid disorders that are uncontrolled can absolutely cause irregular menstruation. Prolactin, which is the hormone of breastfeeding, we as women secrete it in small amounts every day. If that is out of sync or out of production, then absolutely can cause irregular cycles. And of course, if the patient is sexually active, ruling out pregnancy is another big one. Now, if the patient has a poorly controlled chronic disease, so think about things like lupus that is very poorly controlled or diabetes that is very poorly controlled, that can also be a cause for irregular cycles. So again, when you're going through the diagnostic criteria, you want to make sure that you're ruling out all these other causes. Okay, so we talked about the frequency of PCOS. Remember, 6 to 12% of reproductive age women in the US, or approximately 5 million women. We talked about the clinical presentation, so most commonly irregular cycles, also signs of elevated testosterone. We talked about how those can present clinically. We talked about the general health implications of PCOS. We talked about how to diagnose PCOS, so Rotterdam criteria is probably the most widely accepted today. And now we're going to shift gears and talk about how to treat PCOS. So remember that if you do have questions, feel free to add them into the chat box. I will be addressing those questions live after this recording is stopped at the end of the presentation. Are you guys following so far? Type yes in the chat. If anything is unclear, go ahead and throw that question in now before we move into treatment, because that's where we're going to spend the bulk of the rest of the lecture. So if you're following along and everything is clear, wonderful. Okay, I'm seeing some yeses. Great, awesome. Okay, so we'll go ahead and keep going. So when you talk about treatment, now for me as a fertility specialist, when I counsel patients about treatment, I always focus on these 3 aspects. So number 1, lifestyle. How can we optimize our lifestyle or make changes to our lifestyle that may improve our PCOS management? Number 2, supplements. So are there supplements that may help PCOS specifically? And then 3 is medical management. I think one that I would like to add that I didn't in this slide would also be integrative practices. I think in Western medicine, we are just now starting to scratch the surface of the benefits to integrative practices. So integrative medicine or complementary medicine are going to be things like supplements, like culinary medicine, so food is medicine, but also things like acupuncture, meditation, visual imagery, things like that. So really important to be talking to a healthcare provider that includes all of those things as part of their management plan. So today we're going to focus on lifestyle, supplements, and the medical management of PCOS. I do apply these 3 branches to all aspects of fertility diseases that I treat. Okay, so lifestyle. I wanted to focus on nutrition. Nutrition is just one aspect of lifestyle, but I thought there was so much out there about PCOS that it was worth having a full slide on it. So in September 2021, we're talking a little over a year now, there was actually a study published, Dietary Patterns and PCOS. It was a systematic review. And what they found, is that diet plays a very important role in the clinical picture. When you think about the metabolic component of PCOS, the insulin regulation, the tendency towards obesity, it makes perfect sense that diet would play such an important role. So what we want to focus on, fruits and vegetables, and I'm just going to go in clockwise fashion here, fruits and vegetables that are low in glycemic index and usually non-starchy. I put some examples here. I actually have a full slide on this on my social media, so you can go into my Instagram and check that out for the full list. But artichokes, I think, is a great option. I don't think we think about that one enough. Asparagus, Brussels sprouts are a personal favorite of mine now that I'm an adult. Broccoli and cheese, who can say no to that? cauliflower that's now taken over as a replacement for many of the traditional carbs, and several others. So I think a lot of times when we think of fruits and vegetables, they don't get us excited. But when you start to think about all you can do with the fruits and veggies in terms of being low in the glycemic index and non-starchy, you find that there's actually a lot of opportunity there. Fish is one that we definitely don't incorporate enough into our diet. Fish is rich in omega-3 fatty acids and can definitely be helpful in the nutrition aspect of PCOS. Lean protein, so lean red meat and poultry, turkey, chicken. You also have your nuts, so almonds, pumpkin seeds, sunflower seeds, sesame seeds, poppy seeds, whole grain products and legumes, and fatty acids that can be included in things like olive oil, olives, vegetable oils, fish oils. And I think for someone who is really serious about the nutrition piece, and I always tell patients, when you talk about these three things, lifestyle, supplements, and medical management, each branch is just as important as the other. So if you are motivated enough to be working with me in the office, coming in for appointments, taking prescribed medication, etc., then the other two components need to be just as prioritized. So really working with a dietitian who is focused and knowledgeable about PCOS as a disease can help you tailor that nutrition plan that would be best for you. For example, intermittent fasting that is very popular these days, the keto diet also very popular these days. Those two are terrible for PCOS patients. You definitely want to stay away. So working with someone who's knowledgeable in the disease and focusing on these different aspects of nutrition can really provide whole balance and deliciousness, right? Without having to sacrifice. So I thought this was worth using a full slide. And then I did want to talk about exercise in another full slide, because this is something I think, especially in modern day, particularly post-COVID, that many of us, myself included, struggle with. So several studies have looked at the impact of exercise interventions on reproductive function. And generally speaking, the results indicate improvement in menstrual or ovulation frequency following exercise. But when you define exercise, the guidelines for PCOS suggest at least 150 minutes of physical activity per week. If you break that down into 30-minute sessions, that's 5 days a week of 30 minutes, right? And so you're really looking for something that's going to get your heart rate up. It's going to really get you sweating and kind of working. There is a concept called NEAT, non-exercise activity thermogenesis. And this is something I learned in the last year as an adult, already as a practicing physician. So non-exercise activity thermogenesis is the energy expended for everything we do that is not sleeping, eating, or sports-like exercise. So for example, think of if you work in an office job or in a healthcare setting where you're walking the floor, rounding on patients, walking to your car, cooking dinner, all those things would be considered non-exercise activity thermogenesis. And that NEAT is really predetermined by genetics in a large part, ethnicity in another large part, but also your baseline metabolism, right? So there are patients who are going to have a lower baseline NEAT, patients who are going to have a higher baseline NEAT, irrespective of the activity that they're actually doing. But the takeaway here is being on your feet at work, especially in a stressful environment, should not be considered part of your 150 minutes a week. And I think that's where sometimes we maybe have conflict of, oh, I'm a teacher and I'm walking around all day chasing after students, or I'm in the healthcare setting, or, I work at an Amazon distribution center. So I work with, carrying boxes or things like that. So you really want to try and separate out those activities. While they do count towards your non-exercise activity thermogenesis, they shouldn't really be counted towards your 150 minutes. So those are my two slides on lifestyle. I thought nutrition warranted a full slide. I thought sleep warranted a full slide, exercise warranted a full slide, but I did want to highlight sleep. Sleep is typically the forgotten pillar of health, and we saw how sleep apnea can be higher risk in women with PCOS. So making sure that you are sleeping well, if you're not, making sure you're getting that evaluated and treated. Another thing is going to be caffeine consumption, base alcohol consumption, other exposures like toxins such as tobacco, vaping, which is so common these days, etc. really trying to target and do an assessment or inventory of each aspect of, an average day for us, and where is there room for improvement? Where is there room for optimization? Lastly, when it comes to lifestyle, so we talked about nutrition, exercise. We also talked about caffeine, alcohol, and other substances intake. Sleep is going to be super important, and really trying to focus and prioritize that, not only for your PCOS, but for your general health. So I always tell patients that reproductive health is simply a reflection of general health. So if your general health is not good, there's a good chance your reproductive health is probably being impacted. Now we're going to shift gears and we're going to move over to supplements. I want to just preface this slide by saying that supplements, it's a little bit tough to study. As you guys know, supplements is a multi-billion-dollar industry, and it is not regulated by the FDA. So it's really tough to make specific recommendations about specific supplements. There are some companies that are more serious than others, but I did want to at least say, hey, these are out there. It's worth talking to your healthcare provider. Don't just go click Amazon and buy. You really want to make sure you're researching and buying products that are going to really have the ingredients and the active components that you need. So again, fish oil, and I'll go clockwise here, but fish oil rich in omega-3 fatty acids. So if you're doing once a week or less, you may want to incorporate that as a supplement. N-acetylcysteine, or NAC, 600 milligrams 3 times daily. So that's actually quite a large amount. Excuse me, it's thought to be an antioxidant component. So to improve, again, that egg quality that can be impacted in women with PCOS. I do see patients reporting improvement with this, but again, the data is gray. Berberine may be one that you've come across if you think you have PCOS. It works as an insulin sensitizer. The potency has been compared with that of metformin. Again, depends what brand, depends how much, the dosing, etc. In that same line, cinnamon. If you're using cinnamon bark versus cinnamon, flavoring or whatnot, really it's the cinnamon bark that you want. Same thing has been noted to help with weight loss, has been noted to help as an insulin sensitizer. Magnesium. So women with PCOS are 19 times more likely to have a magnesium deficiency. We're just starting to learn more and more about magnesium, its role in our baseline energy levels. And again, sort of magnesium is that cell enhancer. So it helps bring things into the cell and helps those cells use its energy. And so really making sure magnesium is replenished. Again, where you're buying it, how much you're using it, that's all going to be important. Vitamin D, we know that most of the population is deficient in vitamin D. Here in our particular clinic, we recommend sort of standardized supplementing everyone. Zinc is another one. So increasing levels of zinc can improve many of the symptoms like acne, hair loss, excessive hair growth. And then the inositols, specifically myo-inositol and D-chiro-inositol. Supplementing with these two inositols in a 40-to-1 ratio is ideal to mimic what's happening in the body. And these are downstream messengers of the insulin pathway. And so again, it's focusing on that insulin sensitization, improving the hormonal milieu. A few others that have been mentioned, CoQ10, B12, resveratrol. Takeaways from the supplement page, I think number one is what company are you using? Where are you getting them from? Number two, how much or what dose should you be taking to actually show therapeutic benefit? And number three is working with someone who's experienced and knowledgeable in all of this, who really has the background. This was something that I began to explore probably 1.5 years ago now. And I have some really great resources for anyone who's interested. I can provide names after the session, but really working with someone who's knowledgeable in this area, and making sure that you're being forthcoming with your healthcare provider about what you are taking, because there may be interactions and whatnot. So you really want to make sure that when we're asking about medications, vitamins, and supplements. We want to know all of it, because we want to know what you're taking and how much of it you're taking. One that's not on here and actually has been shown to give really good results, Vitex, which is chasteberry. And then another one is spearmint tea, also has some good data. If you're going to use spearmint tea, you want to make sure you're doing it loose leaf. Hot, 2 cups a day, 1 in the morning, 1 in the evening. Most studies with supplements, and they are going to vary study to study, supplement to supplement, but generally speaking, the typical usage is 3 months before you begin to see a change. Okay, so if you're focused on incorporating supplements as part of your natural treatment for PCOS or non-prescribed treatment for PCOS, you do want to make sure that you're planning on a minimum of 3 months usage, and from then on, you would incorporate it into your daily regimen. I don't have a slide for it, but I did mention it at the beginning of my talk. Integrative practices such as acupuncture and meditation. Acupuncture specifically has some pretty good data for PCOS as well. Okay, so now that we focused on lifestyle and supplements, we're going to wrap up talking about medical management. And when you talk about medical management, that's specifically what are you going to be doing in your physician's office with your provider. And so the number one question here is pregnancy desired, yes or no? So you have your symptoms, you saw your doctor, you went through the evaluation, you now have a formal label of PCOS or polycystic ovarian syndrome, and that disease needs to be treated. When I counsel patients, I say, think of PCOS as a chronic illness. It always needs to be actively managed. So you are either actively suppressing the PCOS when not trying to get pregnant, or you are actively trying to conceive by inducing ovulation. We'll talk about that in just a minute. So you never really want to spend a prolonged period of time where you're not on anything. Of course, the lifestyle, of course, the supplements are important, but really PCOS needs to always be actively managed. Either you're trying to get pregnant or not. Okay, so if pregnancy is not desired, then progesterone is the missing hormone. And this is the hormone that should be given in a regular fashion to balance out the unopposed estrogen that is characteristic in PCOS. It may be given in many forms: birth control pill, progesterone only pill, progesterone IUD, etc. There's many different forms, but it's important that progesterone is given to balance out that unopposed estrogen. If pregnancy is desired, then the goal is to get the woman to ovulate, also known as ovulation induction or OI. So when you see us writing in our notes, ovulation induction or OI, this is what we're talking about. We're trying to get you to ovulate to try and achieve a pregnancy. If pregnancy is not desired, the focus is going to be on progesterone. Time to pregnancy, let's say it's someone who just started college, they know they're not going to be pregnant for at least 4 years, then a progesterone IUD could be a really good option for them. Sometimes that will decrease the cycle and flow of their menses as well. So it all can be tailored depending on the patient's individual desires and individual characteristics. But if pregnancy is desired, then ovulation induction needs to be the focus. So since 2014-15, and I say that because it was October of 2014 that it was presented at our annual reproductive medicine meeting, and the full article was published in 2015. The first line treatment for ovulation induction for PCOS is Femara. It's also known as letrozole. One is just the commercial name, one is the generic name, and they're tablets, so they're taken orally. Letrozole is typically prescribed as 2.5 milligrams, which would be 1 tablet a day, for 5 days. You can increase that to 2 tablets a day for 5 days or 3 tablets a day for 5 days. So that's max dosing, is those 3 tablets daily. Now, some women may not respond to traditional oral medication. So alternatives could be switching to Clomid, which is one you may have heard about, could be the addition of metformin, dexamethasone, injectables, prolonging the days, combining letrozole and Clomid. So there's several different ways that one can try to provoke a response in a patient who is not responding to these medications. There is also a surgical option. It's called ovarian drilling. Now, remember, this 2014-15 is only about 10 years old. So pre that, in women who were resistant to an older medication known as Clomid, ovarian drilling was considered a reasonable approach. And this was a surgical procedure where we basically, remember that, go back to that chocolate chip cookie, we poked holes in the cookie to decrease the amount of volume. And so with that, some women saw return to normal monthly menses, or maybe not return to monthly menses, but they did have a better response to those ovulation induction agents. So this is kind of a summary slide, but again, each case needs to be tailored and individualized, and every patient is going to be different. Okay, so we have reached the end of our presentation. Thank you so much for listening. Really, the work just begins here. If you think you have PCOS, if you think you have some of the symptoms I mentioned at the beginning of the talk, you really want to be working with a provider who's knowledgeable in the disease, such as myself or one of my colleagues. And you really want to make sure that you're focusing on those three aspects: lifestyle, supplements, and then the medical management. So I'm going to go ahead and stop the recording, and we'll go over any questions that might be. Let me stop the share first. There we go. Okay, and then I'm going to end the recording. Let's see.